Welcome. My name is Jason Stankiewicz, and I'm a second-year pulmonary and critical care fellow at the University of Maryland. Today, we're going to discuss management techniques for nicotine use treatment, specifically using nicotine to treat nicotine, or nicotine replacement therapy. The discussion today will focus on the backbone of our known pharmacologic treatments, that is nicotine replacement therapy, or NRT. As we'll see, there are several methods of NRT, including those with combined or synergistic effects, with the ultimate goal to have our patients kick the continued habit of ongoing nicotine use. Note well that this slide does not condone littering. I think that this will be a very practical-based session in that our roadmap for today will consist of 1. Reviewing the rationale behind NRT, 2. Reviewing the evidence and efficacy for NRT and nicotine use treatment, and 3. Reviewing practical considerations for administration of NRT. Firstly, we must note that combining counseling and pharmacotherapy has been identified as the most effective treatments as opposed to either modality alone, and we should strive for this. Secondly, in terms of pharmacotherapy, there are currently 7 different first-line medications for nicotine use treatment. Those highlighted in green today are the ones that we'll discuss. So what is the rationale behind NRTs in treating nicotine addiction? Nicotine found within NRTs are pharmacologically the nicotine found in cigarettes and vape devices at the end level. As such, this exogenous nicotine is an agonist at nicotinic acetylcholine receptors in target organs, including the brain, as well as the psychoactive effects. NRTs are beneficial for a few reasons. 1, NRTs activate these receptors in a way to decrease craving and those nasty withdrawal side effects and break that cycle of false security mechanism at the mesolimbic system level. 2, NRTs do this in a safe way. These products do not include the tar and terrible carcinogenic compounds found in cigarettes. And 3, NRTs, as reviewed in this curve, do not achieve those rapid blood-brain levels compared to cigarettes. Lozenges, gum, patches, they're not really of the same addicting nature. Okay, so in theory, NRT should work, but does it? Short answer, yes. The Cochrane Collaboration, better known as the rock stars of evidence-based medicine, bring us these studies. So study 1 was published in 2018, which reviewed NRT versus control for smoking cessation. Its analysis included multiple levels of NRT. 136 studies were included, including about 64,000 patients. Patients, they smoked on average about 15 cigarettes per day, and they were all willing to quit. Overall, you can see the results here, which lead the group to conclude that there is high-quality evidence that all of the forms of NRT can help people quit who really want to make the quit attempt. We can see that the chances of stopping smoking were increased by about 50 to 60% compared to a control. So as we can see in this review, we understand why nicotine replacement therapy is really the backbone of pharmacotherapy here. So NRT works, but is there an optimized way that we should prescribe and administer it? Take a look at this image. No, you're not hallucinating, but this is a graph of the natural secretion of insulin throughout the day, released in a basal and a bolus fashion. This may help us conceptualize and dose insulin to match the natural physiology. However, can this concept help us understand and dose NRT? I think it can. Recall that in smokers, nicotine is present throughout the day. Recall additionally that sharp, rapid uptick in nicotine concentrations after a puff of smoke is inhaled. Perhaps we can prescribe a longer-acting NRT paired with a short-acting NRT as needed for those urges and social cues. Let's go back to the rock stars, the Cochrane Collaboration, which would, by the way, be a pretty great band name. Study 2 was published in 2019, which reviewed randomized controlled trials comparing one type of NRT versus another on long-term smoking cessation and those willing to quit. So 63 trials were included, about 41,000 patients, and those who smoked 15 cigarettes per day who were, again, willing to quit. There were many findings from the study, but briefly, the authors concluded that there was high certainty evidence that using combination NRT versus single-form NRT can increase the chances of successfully stopping smoking. Additionally, there was similar efficacy in using any single form of NRT, patch versus gum versus lozenge alone. Also, it accomplishes this with similar safety profiles. Therefore, when we can do it, we should advocate for combined NRT. Let's take a dive into the practical of prescribing NRT. Just as a brief comment are those NRT agents, there are numerous short-acting agents. These include, most commonly, gum and lozenges. There are also inhalers and nasal sprays. However, there is currently only one long-acting agent, and that is the patch. There are a few comments needed on precautions in prescribing NRT. As overall, it is safe, but some word of cautions. Theoretically, nicotine can have adverse cardiac effect by atherogenesis and potentially coronary disease. However, those who are smoking are arguably in highest need of a smoking cessation product. And so far, according to 2018 cardiac expert guidelines on smoking cessation, there are controlled trials, longitudinal studies, and case-controlled studies of NRT in patients with cardiovascular disease that report no increase in adverse effects, such as death, MI, repeat hospitalizations compared to placebo. Additionally, another study showed that NRT administered within 48 hours of an admission for an acute coronary event did not have adverse mortality effects, hospital length of stay, readmission, and cost effects in the short term. And overall, the evidence to date suggests an overwhelming benefit in compared to risk. Additionally, those nicotine levels achieved by NRT are often significantly lower than those of smoking. Other products to be aware of are the fact that nicotine use replacement is a pregnancy category D, as well as there's precautions involving breastfeeding. There's also precautions of those less than 18 years of age. Other things to be aware of, specifically in terms of NRT nasal spray and inhalers, the potential for these products to cause bronchospasm, as well as exacerbating nasal disorders. A word on nicotine gum. It's a short-acting agent, and the onset of action is about 20 minutes. It's found in 2 and 4 milligram dose packages. Instructions are very important as it's not intuitive compared to your standard bubble gum. So there should really be no food or drink 15 minutes before or during the use. The proper way is to chew the gum just enough to release the nicotine, just enough to be indicated by a tingling sensation. Once tingling, then the person can stop chewing and place the gum between their cheeks and their gums until the tingling stops. Then one can repeat that step over. Overall, it should be repeated over until the tingling resolves, and this one piece should last about 30 minutes. There are some adverse effects, and those include an upset stomach, salivation, jaw soreness, headache, nausea, vomiting, potentially lightheadedness. The lozenge is another short-acting agent, and the onset is still about 20 minutes. These can be purchased over the counter. The dosages are similar to those of gum. The proper way to take lozenges is to place it in one's mouth like a hard candy. Notably, again, remembering not to eat or drink 15 minutes before or during the use. This should then be set between the gums and the teeth. The nicotine could continue to tingle and will gradually resolve as the tablet dissolves over about 20 to 30 minutes. Some adverse effects include, again, nausea, reflux, cough, headache, insomnia, and potentially flatulence. The nasal spray is a little less common, but another short-acting agent, onset of action about 5 to 10 minutes. The dosing is in one spray is equal to about 0.5 milligrams. These can only be purchased as a prescription, and because of the more rapid onset of action, this medication can potentially be more addictive than the others reviewed so far. It's actually a second-line agent in this regard. One should avoid notably sniffling, swallowing, or inhaling surrounding the product. Again, one should avoid food and drink about 15 minutes prior and during. Some adverse effects could include nasal irritation, rhinitis, congestion, as well as a cough and headache. The inhaler is another short-acting agent, onset of action being about 5 to 10 minutes. It may be preferred for those unable to tolerate perhaps oral-based nicotine products with poor gums or gum disease. Each dose container contains about 4 milligrams of nicotine. These can only be purchased after prescription. Because of the more rapid onset, again, theoretically, there could potentially be a higher risk of addiction in these cases. The result is, again, a second-line agent. It's used by puffing, notably in the back of the throat. The goal is not to get this product to the lungs. There should be, again, no food or drink 15 minutes before as well as during the product's use. The patch. It's the only available long-acting agent. The onset of action is about 2 to 4 hours. Additionally, has a very long duration into the 24-hour range. Dosing includes 7, 14, and 21 milligram per 24-hour patches. The dosing of the patch will generally be divided based on how much the patient smokes or is addicted. The 14 milligram patch should be used for those with low dependence, whereas those with high dependence generally use a 20 milligram per day patch. These are often over-the-counter. The patch should be rotated every 24 hours based on their site. You can consider removing the patch if there are some issues sleeping overnight. Some adverse effects include headache, local skin reactions, as well as sleep-related issues. I put this here as an aside, mostly for the need for a tool to assess nicotine use. So you could pick one of the many tools of nicotine dependence listed here. Based on this scientific background, is there a practical approach that may be helpful to guide us? Here are some strategies taken from a paper published in 2017. Generally, they provide a regimen that ultimately tapers a patient from nicotine. So most reports use NRT over about 12 weeks, but there are considerations greater than 13 weeks use for certain users. This paper outlines first checking the patient's nicotine addiction risk. If there's a high risk of addiction, One may use the higher dose tablets and patches, so a 21 milligram patch and a 4 milligram short-acting agent. If there's a generally low risk, one may elect to use the 14 milligram patch as well as the 2 milligram tablet. Subsequent to that, you can see the outline for weeks 1 through 6. So for this patient, you would use a 21 milligram patch, and then each day you would subsequently go down by the number of tablets or short-acting agents used. For day 1, you would use 8 of the 4 milligram tabs. The subsequent week, you would use 7 tablets per day, subsequently 5, 3, 2, and then 1. And the goal would be to use them ideally PRN, but some may advocate using a scheduled short-acting basis to make sure that your patient is getting some short-acting nicotine. Subsequent to that, the following 4 weeks, you would go down on the patch and then gradually taper down on the tablets. The following week would be another 7 milligram patch, and then the last 4 weeks would really be no prolonged patch, but rather only as-needed lozenges. Another recommendation may be to include a placebo or sugar-free gum within this process. Here we also see that there are 2 more variations on this method of using combined nicotine replacement therapy or short-acting and a long-acting agent that may work for some of your patients. And that concludes our whirlwind tour of NRT. I hope that this session was a practical one, in that we can now understand the rationale, evidence, and practical considerations for using NRT as one of the backbone modalities in our treatment of nicotine use. So the toolbox is beginning to fill, and I hope that you will continue to join me as next week we're going to discuss other pharmacotherapies. So thank you again for taking the time to view this series, and please take care.